Hi there and welcome. My name is Dr. Marlena Jabara, and I'm the proud founder of RadPodSquad. The RadPodSquad Fellowship offers an immersive learning experience tailored specifically to podiatric imaging. RadPodSquad combines comprehensive curricula, cutting-edge techniques, and on-demand access to training that will provide you with the new knowledge and skills that you need to boost your confidence in imaging and truly make a difference in treating your patients. Check us out today, radpodsquad.com. Hi there and welcome to Plantar Plate Imaging. My name is Dr. Marlena Jabara and I'm a board certified MSK podiatric radiologist. Let's take a look at part 1, normal plantar plate anatomy. So this is the type of medial toe crossover that we're looking to avoid in early plantar plate imaging and accurate diagnosis. By assessing the plantar plate at a stage earlier than the one seen here, we can prevent these gross malalignments that we can see in forefoot imaging. So what's happened here is that there's been a plantar plate tear at the second MTP joint, usually on the lateral or fibular side of the plantar plate. And you can see that that has rotated and now we have a crossover of the second to the first toe. This can cause a host of issues, including pressure and ulcers from the crossover of the second to the first toe. And that's a serious consideration in our diabetic patient population. Let's take a look at how we begin, which is usually with our x-rays. So when we're looking at our x-rays, we really want to take a look at the lateral where we can see a flexion deformity as seen here at the PIP joint, and that's called a hammer toe deformity. In addition, we can see the beginning on the frontal view of a medial toe crossover where the skin of the second toe is beginning to come close to the first. And of course, looking at sesamoid rotation can give us a look at where we begin to have our greatest momentum of toe off. So as we shift the sesamoids over towards the fibular side, we can see that we're losing our sweet spot of the hallux MTP joint at our greatest point of toe off, and it's beginning to slide towards using the second MTP as additional toe off strength. X-rays can also tell us a lot about biomechanics when we look at our 3-view series. So after we've looked for our standard fractures and whether or not we have malalignments, including looking at the base of the second relative to the middle cuneiform to assess our Lisfranc injuries, we can begin to see other changes in bones that may tell us about biomechanical stressors, including what's seen here, which is this cortical thickening seen at the second metatarsal. In addition, notice it's slightly bowed. And so there have been changes perhaps in the biomechanics related to how we heel strike, move to the mid-tarsal region, move between early and late flat foot phase of gait, eventually to toe off, and the additional changes in the metatarsal alignment at the bases that can be seen when we need increased ground reactive forces to help us propel the patient from supination into pronation to toe off. And we can see what can happen as a hammer toe deformity as we begin to have second plantar plate tears. We can begin to wear out the plantar plate, creating a situation where we begin to have a hyperextension at that articulation and a result in hammer toe deformity compensatory at the PIP joint. Furthermore, we can see that the forefoot in this case is beginning to spread out where we have this overlap at the metatarsal bases, a situation that can be seen in metatarsus adductus or forefoot inversion. So I-inversion is where we're going to get the stacking of the metatarsals. So the additional second metatarsal stress can be seen here in this case by the cortical thickening. In other patients, we might actually see flattening of the second metatarsal head as the biomechanics of the second MTP joint is altered, creating a situation that creates accelerated osteoarthritis through our second MTP. Looking at anatomic considerations in metatarsal head size, we begin to see form and function. The first metatarsal head is responsible for a great amount of pressure experienced at the toe-off phase of gait, and it is wider rather than taller. In addition, there are sesamoids that fit into a helical articulation to help offload the great amount of forces that are experienced through the great toe during toe off. Looking at the lesser metatarsals, these are responsible for a great amount of load transfer. So they're taller rather than wider. Furthermore, looking at the first MTP joint, we have a sesamoid apparatus that is invested by the accessory collateral ligament. And that's different from the lesser metatarsals, which is the bulk of our conversation today. We're going to be taking a look, in this case, at the first MTP, which is sesamoid, the accessory collateral ligament. We have the proper collateral ligament, And that's going to join some of the abductor hallucis, the muscle, and the tendon to reinforce the collateral ligament complex seen here. Furthermore, the space between the sesamoid and the base of the proximal phalanx is filled by the plantar plate at the center aspect of this articulation, and on either side by the sesamoidal phalangeal ligaments. Removing the first metatarsal head, we can expose the plantar plate seen here with a star, and on either side, that's where we're seeing that sesamoid phalangeal ligament on either side of the plantar plate. Of course, the sesamoids are joined by the intersesamoidal ligament, and we can see the flexor hallucis tendon tunneling through the plantar aspect of this articulation with a fibroosseous tunnel that is extending itself toward the flexor hallucis brevis. So these are static and dynamic. The static considerations are the sesamoids and the dynamic stabilizers of the first MTP joint. Furthermore, at the first MTP joint, we have these collateral ligaments, and those are further reinforced medially with the abductor hallucis and laterally with the adductor hallucis, both the transverse head and the oblique head. Looking at the lesser MTP for anatomic considerations, we can take a view of the metatarsal and the proximal phalanx and begin to dissect away some of that anatomy. So I've drawn here the deep transverse metatarsal ligament, which forms the floor at the level of the metatarsal bases. The deep transverse metatarsal ligament meets the accessory collateral ligament at a point where they'll create a juncture at the plantar plate. So we can see that here in cross section. We have our plantar plate, and where it meets that deep transverse metatarsal ligament, that's when we have the investment of the accessory collateral ligament. Superficial to the accessory collateral ligament, we have the proper collateral ligament, and we also have the interosseous tendon coming through between these regions. So we've had the muscle moving into the tendon, and this interosseous tendon will join the lumbrical tendon past the point of the plantar plate at the MTP joint to form a further reinforcement of this oblique portion of the medial aspect or the tibial side of the plantar plate. So once again, the anatomy that we're looking at here is the plantar plate deep to the metatarsal head. We have the accessory collateral ligament, which is joined by the deep transverse metatarsal ligament at the level of the MTP joints. Furthermore, on the medial plantar aspect, we have reinforcements by the common tendons of the interosseous tendon and the lumbrical tendon reinforced on this medial tibial side. Of course, on the lateral side, we have the interosseous tendon forming further support at the juncture where the accessory collateral ligament is going to form with the deep transverse metatarsal ligament. And there's a lot of reinforcement on the curves because as the plate begins to wear out, we begin to have rotational malalignments, and there's reinforcement for that type of rotation. You can appreciate on this illustration how I've drawn in the plantar plate. It forms a hammock underneath the metatarsal phalangeal joint. So we can see that here, this whole black basket weaved underneath to support the MTP joint. Looking at the metatarsal heads in transverse, we can begin to appreciate we have those plantar plate, we have the accessory collateral ligament, and where that joins the deep transverse metatarsal ligament, we have that reinforcement. Of course, the proper and accessory collateral ligament really can't be dissected from one another in the course of reading an MRI if they're normal, because both are low signal and do not contain water. In between the articulations of, say, M2, metatarsal 2, and metatarsal 3, we have the metatarsal bursa, and that's a potential space that can become inflamed and enlarged during times where we have rotational or increased stressors at the metatarsal head. Of course, I've left out, let's just go through the entire bit of anatomy, going through the entire circular apparatus of the axial image. With our extensor digitorum longus and brevis tendon, we have our sagittal bands that keep the tendon centrally located. This blends imperceptibly to the region of where we have our proper and then our accessory collateral ligament. Of course, that again is going to blend into the region where it joins the deep transverse metatarsal ligament at the level of the metatarsal head, and then to the plantar plate we go. Of course, we have our flexor digitorum and flexor digitorum brevis tendons joined by its flexor tendon sheath. We have neurovascular bundles that are superficial to the deep transverse metatarsal ligament as seen here and here. Furthermore, I've added in our interosseous tendon and the lumbrical tendon here seen as separate decussated areas at the level of the metatarsal, and they'll join to form a common tendon band that will reinforce the medial aspect of the capsule. And of course, on the lateral aspect, we'll have that interosseous tendon that can reinforce that capsule on the fibular side. Looking at plantar plate imaging in the cadaver, which the surgeon wants to master, of course, we can dissect from the dorsal aspect of the articulation. The proximal phalanx is seen in the lower part of the image, the metatarsal head seen in the upper part of the image. Once we dissect through those extensor tendons, the digitorum brevis and the longus, we get to expose the bony structure seen shiny here, exposing the capsular contents and removing the metatarsal head. We can expose the plantar plate. And the plantar plate seen here in the gross specimen to the right, we can see that shiny plantar plate, that plantar oval shaped structure that's about 2 centimeters long and about 2 millimeters in thickness. 2 to 5 millimeters is what it's been described as. And we can see on either side of the plantar plate the capsular areas of thickening. Here, the plantar plate has been drawn up for us to show us that cross-sectional thickness of about 2 to 5 millimeters. And of course, we can see for a second, I wanted to just stop and give us some inkling of what's to come in terms of the plantar plate pathology. So when tears occur at the plantar plate, it's going to be seen in early stage tears to have a transverse rent or transverse tear. So we'll be tearing medial to lateral in this case. But as the tear becomes a higher grade, 3s and 4s, we're having a longitudinal extent of tear. And that's a tear that's going to dissect along the longitudinal fibers and allow what's called buttonholing to occur, where the metatarsal head can actually penetrate through the plantar plate itself and, of course, dislocate. Plantar plate MRI protocol, just a second. I'd like to talk about using the proper field of view. In order to see the forefoot, you'd want to use a field of view that's no more than about 8 to 10 centimeters in total field of view. And of course, the slice thickness, being that we're looking at structures that are on the order of between 2 to 5 millimeters, we'd like a section thickness of about 3 millimeters and no more than that on any of the given sequences. Of course, high resolution imaging, always better for these small structures to be able to define them with clarity and accuracy. Now let's turn to the MRI. So what I've loaded up here are sagittal and transaxial images, and that's really the workhorse of defining plantar plate imaging. So we can see in this sagittal image, what I've loaded up is that you can see the plantar plate itself as this low signal band imperceptibly drawn to the flexor tendon itself. We can see some of the intermediate signal intensity at the level of the cartilage, the hyaline cartilage that divides the metatarsal head and the proximal phalangeal base. Of course, this is cortical bone, which is of lower signal intensity than the marrow element seen here, which is of slightly higher intensity, slight amount of physiologic joint fluid seen here. Looking at the transaxial image, we can see what we're looking for is a U-shaped structure as we described in our illustrations, looking from the region of the flexor tendon to the level of the plantar plate, of course, in the region of the accessory and proper collateral ligament, which we really can't dissect off of one another in the normal situation. So this is at the level of the typical rectangular shaped metatarsal head that is taller rather than wider. And here we can even see some of the attachment of the phalanx, so the plantar plate phalangeal ligament at its typical triangular shaped proximal phalangeal base. And of course, just to throw in for extra, there we can see our sesamoid complex, we can see the flexor tendon, and of course the collateral ligaments and the accessory collateral ligaments reinforced with our the beginnings of our first plantar plate complex beginning at the metatarsal side. So here's anatomic considerations at that distal attachment loaded up for us so we can see a better example of what it looks like at the attachment of the distal plantar plate phalangeal attachment seen here with low signal paired attachments on the proximal phalangeal base. I'd like to make a note about a normal plantar plate recess, which is generally thought to be no greater than 2.5 millimeters in width. So at the central aspect of the joint space, we have a normal recess that we can see from medial to lateral will seal up and become a formed attachment between the plantar plate and the proximal phalangeal base. But at the center aspect of the articulation, there is this normal recess that's usually on the order of 2.5 millimeters. Are you ready to take your podiatric imaging skills to new heights? Check us out at RadPodSquad.com. Explore our online learning community. And don't forget to like and subscribe to our YouTube channel for more enriching content.